Welcome back, everyone. I hope you are having a great summer so far. If you're in the United States like us, or wherever you are in the world, drop that in the comments. Let us know, what's the weather like for you? It's hot for me here in Maryland. But you are in for a special treat. We have our practitioners, Dr. Alex Bingham. He is acting as a health consultant, lead practitioner Kimberly Quirk, and Dr. Neil Nathan is our special guest today. So before we jump in, we'll do our quick disclaimers, but this live is really for you if you find that you are one of those people who identifies as highly sensitive. So we're going to be discussing healing for sensitive people, and we're going to have those expert insights from both our MC360 practitioners as well as Dr. Neil Nathan. So this presentation is for informational and educational purposes. It is not meant to treat, diagnose, cure, or prevent illness. Please be sure to discuss any recommendations with your healthcare provider. Some of the links mentioned during this presentation or on our website are affiliate links, which may mean Mast Cell 360 may take a very small commission if you purchase through our links. We only recommend products that we love and use personally or use in the Mast Cell 360 clinic. So like I said, today we're going to be talking about understanding reactivity, working around that reactivity. Where do you start when you're sensitive? And if we have time, we will do a live Q&A. So please be sure to only ask your question one time. That helps us keep track. Please make sure it is on the topic of sensitivity with MCAS. And please understand we're unable to answer in-depth personal health questions. So for those who are not familiar with Dr. Neil Nathan, he's the author of the popular book Toxic, as well as the book The Sensitive Patient's Healing Guide. I believe he mentioned that he has another project that he's working on, as well as a second edition of Toxic coming out with some updates, and that will be out in August. So be sure to be on the lookout for that updated version. All right, so now let me welcome Kimberly Quirk, Alex Bingham, and Dr. Neil Nathan. Thank you so much for being here today.
Okay. Thanks for having us.
Yeah.
Good to be here.
Do you want to kick us off with a question?
Yeah, so the question I had, Dr. Nathan, was, have you found that most sensitive people have always been sensitive in some way, even earlier in life? Is it like a lifelong kind of thing, or is it been more they get to a point in their life where they've had some toxicity and that's kind of taken off?
So I think my answer would be some. Sensitivity involves, as we're going to get into in this program, usually dysfunction of the autonomic nervous system, the vagal system, and the limbic system. And the limbic system is needed, as we know, to protect us, to keep us safe. So from the time we're in our mother's uterus, our limbic system is actively looking at what is safe and what is not safe. And none of us have had perfect childhoods. So depending on what we were exposed to in childhood, whether it were recurrent ear infections or throat infections and we took antibiotics, whether we had surgery, whether our parents were not attentive to us, they each had two jobs to do, whether we actually had abuse. And that continues into teenage years where there might have been abuse on Facebook or other areas in which we were bullied or things of that nature. Again, surgeries are other things. So what's happening to us during that time is our limbic system is becoming increasingly hypervigilant about the stimuli that we're being exposed to from the perspective of safety. And if our limbic system doesn't think we're safe, it is going to make us more and more hypervigilant and more sensitive. So for some people, they have a slowly growing increased sensitivity from childhood on. But for some people, that isn't sudden, but it comes on from a particular trigger, particularly in our world. Mold toxicity and Lyme disease are the two biggest triggers we have. And so you might not have been particularly sensitive, But if you've got mold toxicity or Lyme disease, you can become increasingly sensitive, particularly if it is not diagnosed in a timely way or treated in a timely way. So my answer, Kim, is sometimes people have been sensitive all along, and the straw that breaks the camel's back is mold exposure or Lyme disease, and sometimes it just comes on from exposure.
Thank you.
Okay, Alex, do you have a question you would like to ask? And just a reminder, you're muted. We're trying to fix the audio for everyone.
Okay, well, that's a perfect segue. And Dr. Nathan, I wanted to just greet you and say that we're honored to have you here. Also, I noticed that there are people from Sweden, UK, Texas, all over the country already listening. So welcome. And I know that this is not a perfect distinction, but how do you make the distinction between a sensitivity that might be more on the physical intolerance versus on the nervous system dysfunction side of things?
Okay, so I use the word toxicity and sensitivity differently, and I think it helps to understand them differently. Sensitivity, as you might expect, is related to our senses, the sense of taste, smell, touch, hearing. Those are our senses. So sensitivity is an increased hyper awareness of those senses. That means an increased sensitivity to light, sound, touch, food, EMF, smells and chemicals. That's all neurological. That's all controlled by our limbic system and to a certain extent from our vagal system. However, some things are simply toxic to us. And that means things like mold toxicity or the vast array of environmental toxins that we're all being exposed to on a very regular basis. Now that's toxic. And you can be both toxic and sensitive, and that really does occur for many of our patients. Still muted, Alex.
You're muted. Yep, there we go.
I'm trying to protect everyone from the leaf blower and the weed whacker across the street. It's sometimes hard for me when you have a list of symptoms. And sometimes what I'll do with very sensitive people is to maybe microdose whatever we're trying to onboard, and even as little as like a drop of something in 2 ounces of water, and people will like take a sip. And I tend to think that their nervous system is not tolerating and dysfunctional, if that is the trial that causes them a reaction. I'm wondering if you see that also, or how you might differentiate that.
I'm not sure what you're asking, Alex.
Maybe I could. So
when I start working with a patient, one of the most important things that I do at the first patient visit is to try to ascertain how sensitive they are, because that will determine our starting point on what we give. I mean, for example, in the mold world, there are people who have a very strong constitution, and we can quickly put them on large doses of clay, charcoal, chlorella, what have you. With our sensitive patients, if we do that, we're going to just throw them under the bus. They will have a horrific experience, and that may go on for months. It's not just a little bit. It could be semi-catastrophic. And unfortunately, many of them have learned how sensitive they are by having that experience, by working with practitioners who, unfortunately, this group understands sensitive, but most medical practitioners, from my experience, don't. And so they basically assume that, well, you're just like a regular person, so I can give you what I normally give people. And that's why it's so important at the first visit to ask people about what have you taken and how has your response been? Because usually they will tell you at the first visit, you know, I tried taking a little bit of Claritin and I just couldn't do it. Or I tried taking quercetin and I couldn't do it. And so they're already telling us, whoa, okay, we're sensitive here. we're going to need to start with really tiny doses. And depending on how deep that goes, they may be also saying, I'm not ready to take anything for mast cell activation until I get my limbic and vagal systems rebooted here. So at our first visit, if you ask the right questions, if you're really paying attention, you can begin to get more accurately on board with your patient to keep them from having a bad experience.
Yeah, that was a much better way of putting it. What I guess what I was wondering is that if I have done that and I'm wanting to try something, but I'm being very careful, I might start with either a sprinkle of something dissolved in a certain amount of water or a drop, and I'll have them just take a sip. Now, if they have a big reaction, I tend to think we need to work on the nervous system first and not try to onboard any kind of like supplements or medications for a little bit until they can kind of get some strength. And I'm wondering if you agree with that or you have a different take on it.
No, I absolutely agree. If someone can't take even a drop of a homeopathic or a sip of something, they're literally saying, I need my limbic and vagal systems rebooted first because I'm not going anywhere until I do. So for folks like that, I will usually say you need to do a minimum of 6 to 8 weeks of limbic and vagal retraining, and then see if you can handle a tiny bit of materials that we use for mast cell. And that sets the stage eventually for being able to treat whatever the major trigger is, be it mold toxicity or Lyme disease. So yes, I absolutely agree with you.
Okay, that's great. Jamie, did you have another question?
Yeah, like following that up, Alex. So I think, one of the things that we see a lot is that when people, so we know that we need to do limbic if they can't tolerate anything. But if they're at a point where they maybe have a few things on board in tiny amounts, and then they try a new one and they react to that new food or supplement, even in a tiny amount, do you typically find it helpful to stop and try something else? Or do you wait for that reaction to calm down and try that same thing again?
No, that person's limbic and vagal systems are literally yelling at them, absolutely not. I have a phrase which I'd like to patent, which I call flying under the limbic radar, in which that's how I treat all of our sensitive people, which is I try to give them something, a dose or substance in such a tiny amount that the limbic system doesn't go, I'm not sure that I'm going to let you take that. In which the limbic system goes, yeah, that's trivial. You can do that. And you can build from there. But you have to keep flying under the limbic radar at all times. So if someone reacts to one drop of a homeopathic, I'm not going to try that for a long time. I'm not going to try it again next week. If you do, the vast majority of people are going to have a bad reaction next week. And what you're doing is you're teaching that limbic system that, yes, that is not safe. Yep. Limbic system is going something like, I didn't think it was safe. And now I know it's not safe. So I'm not going to let you take that at all. So again, this is working with, not against, the parts of our nervous system that are trying to help us to heal. And I think that's super important for people to realize that the limbic and vagal systems aren't trying to hurt us. They're trying to warn us and protect us from their perspective. And this is not psychological. From a neurological perspective, they're not sure that this is safe. They're not going to let us do it.
Yeah, thank you. No, I think that makes a lot of sense, that trying something else that the limbic system might not react to is probably the best idea. That makes a lot of sense. Thank you.
Well, I have lots of patients who, with the best intentions, keep thinking, well, Dr. Nathan told me to try this, so I'm going to try this again next week. And they just keep hitting their head against it and getting worse and worse with it. And if they had asked me or emailed me or whatever, I'd say, absolutely not. Do not try that again. Let's move on to something else immediately. Let's not. So I've had people waste 2 or 3 months with one substance trying to onboard it unsuccessfully. And that's just not helpful.
Okay, Alex, I think you're up. You have another one?
You're muted, Alex.
Sorry, guys. We're having a Monday over here.
I'd like to think it was just a one Monday, but I think it goes way beyond today. So let's imagine that you've got someone and they're actually onboarding some things, but like a lot of people that come to see us, they've taken large amounts of these things in the past and blown out of the water, but they are things that you might want to try again. And so if they've got a long list of can't tolerate substance that they were introduced in big doses before, what are some of your favorite ways to help someone kind of revisit these with less fear of reintroducing them?
Okay, it's a very good question. Number one, I'm very fond of low-dose intravenous ketamine. I think sometimes that's a big rebooter of the nervous system. Again, depending on how sensitive the patient is, we might start with a lower than normal dose. Like typically, people might start with 25 milligrams of IV ketamine and maybe work up from there. Most sensitive people can do that, but I have had patients so sensitive that we had to start at 5 milligrams or 10 milligrams. And unfortunately, not all clinics will honor the request to start lower. Many clinics that give ketamine, for example, have a very rigid, we always do it this way. I'm giving you 6 treatments, 2 a week for 3 weeks, and I'm just giving you these doses, and they're not listening to people when they say, I think I should start a little lower. So if you can find someone who will listen to what you're saying about how sensitive you are, that's a godsend. That's a great way to start. Another method that I like that works for some people is NAET. That's the Nambucha pod acupuncture energy technique developed by Devi Nambucha back in the 90s, which involves very, very slowly introducing foods and other substances or medications using acupressure to allow the body to accept that in tiny doses. About 50% of the people who have done that have benefited greatly for it. It's a game changer. And about 50% of people, it doesn't do anything. So it's not like, it's great for some people, but our patients are so compromised that anything that works half the time is worth at least checking out or pursuing. So those are 2 of my favorite, Alex.
Yeah, I found that with the NAT that so many people got a benefit, but it seemed to be that they would have to go back and desensitize over and over again once they had kind of gone through that procedure, and kind of came to think that, well, that's because I'm missing what the root cause is here, and I need to look a little further. What do you think about that?
Absolutely agree with you. So as a corollary to that, after people began to learn about mast cell activation, I attribute that to Larry's book in 2016, which was a game changer. It's Never Bet Against Occam, in which he really lit up for all of us how common and important mast cell activation was. That led to almost every major medical center in this country now has a mast cell clinic. Unfortunately, some of them are really academic, and they will basically not make the diagnosis unless they get an elevated tryptase level or some of the other testing that we do. And those tests are horrifically inaccurate. They just are. So I've had countless patients go to these clinics with obvious mast cell issues and be told, oh, you can't have it because your tryptase isn't high enough. I think the upper limit of tryptase is 13 at this point. I had a patient who had just consulted this week who had a tryptase of 12.6, and they told her, you can't have mast cell activation because it's not high. And you go, no, I don't understand this rigid and inaccurate thinking. The other major issue that these clinics have is they are viewing mast cell activation as a standalone process, which is Sorry you have it. You're going to have it for the rest of your earthly life, but we can help you feel better. And that really bothers me, because if you treat, as you said, root cause, this is about root cause. If we can find what's triggering in the first place, it can be cured, flat out cured. And I've had, and I know you have, hundreds and hundreds and hundreds of patients who've been cured because we found and treated successfully their mold, Lyme, or some other infections that they have, other exposures that they have. So to me, that's a travesty, because so many people are not getting the right approach to their mast cell activation because they don't understand what's really happening.
Yeah, it's interesting because people like Larry Afrin and Theorides will come to our conferences, and they have that because that's their field. They'll have that kind of idea, but they seem to be very open to us at the same time, which has been a great benefit, I think, for everyone.
Yeah. So again, that was my chance to get on a soapbox and rant. Steve Buhner in his books used to call these mini rants, and
right.
So that was my mini rant.
Yeah, our Mast Cell 360's approach is that root cause. Like, we have to find what are those triggers. So Kimberly, do you have I think you have a question about triggers specifically that we wanted to ask Dr. Nathan.
Yeah, we are always talking about removing the triggers to kind of calm things down. Have you found that some people, when you remove the trigger, can actually cause that flare? Like somebody who gets out of mold, and almost like they get worse. Yeah, I have some thoughts around that.
In my experience, if you successfully remove the trigger, the limbic system and vagal systems will mostly reboot themselves. Now, before, I'll go back 15 years before I knew what I knew now about the limbic and vagal systems. Back then, if I treated mold toxicity in people who had multiple chemical sensitivity, over time, their chemical sensitivities literally go away. It took about a year. But that was by purely just fixing the root cause and not understanding the finer details of what else was going on. Now, limbic and vagal treatment is the first thing that I do, so that at this point, once we get the root cause out and we've rebooted those systems, I don't have to do any more rebooting. They can be well much more quickly.
I'm wondering, Kim, sometimes maybe I'm reading it wrong, but sometimes we have a person, we know they've got the mold, but they're living in a very toxic mold environment, and they move out of that before we've done any work with the mold toxins. And is that what you're saying, that sometimes we'll see them get worse?
Yeah, I'm wondering almost if the body starts to detox and then the liver gets overwhelmed per se, or, it's coming through the gut to detox. So the immune system gets upregulated a bit in terms of sensitivity.
Gosh, I just think I see the other way, way, way more commonly, that once we correctly deal with this, the vast majority of people simply get better. Now, they may be having a reaction to something else. While their limbic system is still activated, I don't know what all people are getting reacted to. Now, we focus on mold, but you can also react to a vast array of other chemicals in the environment, like formaldehyde in a new building, which is not off-gassing yet. So it isn't always mold that is the problem in a building. It can be any other chemicals and substances that are there, which honestly, we can't even measure most of them at this point. We can only guess at their being there, and only by taking people out of that environment and putting them back in is it really light up the fact that, oh yeah, this is not an environment that we can be safe in.
Yeah, one thing that that Kim has kind of brought to my attention, and Beth had also, was the whole issue with oxalates and how they're different than histamine and salicylates and things, because they're actually crystals that are in your tissues, and how if you all of a sudden stop eating oxalate foods, you can get a dump, which causes you to feel worse. And we also wonder about when someone leaves a very moldy environment and they get to a cleaner place, if that doesn't stimulate an oxalate dump as well.
Gosh, yes, oxalates are a very definite other sensitizational factor, along with salicylates. I mean, there are other things that will vastly increase what's going on in the body. I can use this opportunity to talk about a couple of other super important issues for sensitive patients that are not recognized or realized. One of the biggies, in my experience, is what I will call jaw dysfunction. People who have severe TMJ, some of them have been operated on for various periods of time. And the body puts an incredible priority on teeth that occlude properly, that fit. And if someone has a jaw or teeth that aren't fitting, literally the autonomic nervous system freaks out. And if that isn't addressed early on, even doing limbic and vagal work often won't work. So I have at least a dozen patients who've had jaw dysfunction that until that was correctly treated, very slowly and carefully, by the way, you can't just suddenly go in there and get an oral surgeon to cram it together. That's a way to make people incredibly sick. It has to be done very, very slowly and carefully. There's a chapter in my book written by Tasha Torzo, who actually wrote a whole book on this whole subject about how important the dental aspect is. So that's a piece that if that doesn't get addressed, nothing's going to fix it until you do that first. Another item in that category is CCI, craniocervical instability, in which if the ligaments at the base of the skull get lax or loose and the skull collapses onto the first cervical vertebrae, that will create a blockage of flow of nerves, blood, lymph, you name it. And if that's another one, that if that doesn't get identified and treated, you can do every limbic, vagal, mast cell treatment known, and you're not going to make any progress until that gets treated as well. So these are not common, but in my world, where this is my whole world, I do see these fairly regularly. So yes, there are other conditions that really need to be aware of and look at in patients who aren't responding to what we normally find works. I don't know, is that what you're getting at, Kim?
That wasn't my detox one, but yeah, absolutely. We see a lot of people with craniocervical instability. The jaw piece is interesting, and I'm wondering.
I was going to say it's really interesting that you brought that up, because I specifically went to an airway dentist and had an airway evaluation done because my sleep has always been horrible. And I know how important sleep is as that foundation for healing. And like, I have the dark circles. My son has the dark circles. So I had us both get airway evaluations done. And I wasn't having sleep apnea when I was asleep, but in a deep meditation where I was doing breath work, trying to get into that parasympathetic state, my tongue would fall back and I'd gasp for air. And in that evaluation, and I had expanders and braces as a child, they were like, you have a crossbite and your palate's still high. And it was very interesting because after that, it just confirmed what I could tell by being mindful and bringing awareness to that jaw health. And so for my son, he's 6 years old, and I work a lot with parents, not just at Mast Cell 360, but in my own private practice. And 100%, if we're not looking at their airway health, I think we're missing a huge chunk of why children are sick today and why we're seeing sick adults. You say it's not common, but I think it's more common than people are realizing.
Yes to both of those.
Yeah. Yeah. Let's see, where do we want to go? Because that was down a little rabbit hole. Alex or Kim, do you have one that you want to ask now, or I can ask a kind of a question that I think comes up with our clients a lot?
Well, I actually have a question here, because I think that it doesn't happen so often now, because so many people that come to see us have already kind of gone through a lot of the blogs and podcasts, and they may have done Beth's nervous system reboot and something like that. But there are still people that come in that have been told that so many of their problems are in their head, and they don't really know about the limbic system and the vagus nerve. And do you have a way of gently introducing those so that people get it, that it's not in their head, it's a brain issue, and it's physiologic?
Yeah, typically what I will attempt to do at a first visit, and I've done this now for years, is to lay out for people the order of treatment for people to get well when they've been sick. They normally come to me because I'm supposed to be a mold expert, and I suppose I am to some extent. But I don't think of myself as a mold expert. I think of myself as someone who works with complex problem solving. Mold occurs, but just because you're in my office doesn't mean we're going to work on mold. That's not how I think or work. So what I'll do with patients is I'll really carefully review their entire medical history, ask them a bunch of questions, much of which they've not been asked before. And then I'll even be specific about that. I'm going to specifically ask questions that will help let them know that their limbic and vagal systems are at fault. Example, one of my first questions to people is, have you become sensitive to anything? Light, sound, food, chemicals, whatever. And if they say yes to any extent, then I'm going to basically say, that's limbic. Have you become anxious, depressed, OCD, mood swings, depersonalization? Any of that, has that come up for you? And most of our patients have. And I'll say, okay, that's limbic. So your limbic system is telling us absolutely clearly that you have symptoms that it is causing you that needs to be rebooted. And then I'll do the same thing with the vagus system. We'll talk about symptoms like palpitations, temperature dysregulation. The vagus nerve, as you know, controls intestinal motility. So almost any GI symptoms, gas, bloating, indigestion, heartburn, constipation, diarrhea. Okay. And they'll say, yeah, I have those things. Shortness of breath, chest pain, chest discomfort. And so I'll say, okay, that's your vagus telling us. So I'm trying to literally take their history apart and tell them how their limbic and vagal systems are lighting up from their history. So, and I'll say, if we don't deal with that first, your body won't let you do the treatment I need to give you for mold toxicity. And Alex, I can't think of only a few people who haven't responded to that by going, oh, I don't think I understood that. I need to. And then might be self-serving. I have them read my books, which talk about this in more detail so that they can really understand it. My biggest difficulty is with teenagers, college-age kids who, from my own children, as I know, think they know everything, and me as their father knows nothing. That's the nature of teenageness, if you will. They are harder to convince that they need to do limbic and vagal retraining, because for them it's like, okay, I've got mold, treat it. And I'll go, well, you've tried to do that and your body's not letting you. Those people I have to spend more time with explaining this. And honestly, even then, some of those teenagers are really unwilling to do what needs to be done to get them better. Sometimes they have to get a lot sicker before they'll finally embrace it and go, okay, I said, okay, we've done it your way. How's that working for you? And they'll go, I'm worse. Okay, you want to try it my way, or do you want to keep doing what you're doing? And some of them respond to that. And again, that's a difficult patient population. It's the nature of the beast.
That's very helpful.
Yeah, especially that age group where their prefrontal cortex is not fully developed. And so they need and they don't want mom and dad to help them, but maybe mom and dad aren't nervous system regulated to be that co-regulator. Yeah, that age group's really hard.
Yeah. I'll often have, I'm sorry, Alex. I'll often have families do limbic retraining together. That can be helpful, especially with younger kids who are like preteen or even younger. Annie Hopper's DNRS program can be done with kids, not all, age 7 and up, if mom and dad will do the basic stop program with them. Just that, it's one of the few limbic programs that little ones can do if the family will do it with them.
Mm-hmm.
Yeah. And in clinic, we've kind of made it more so like the parent needs to do it with, because that safety is coming from that parent. So if the parent isn't, giving signals of safety, that mirror back is going to keep that kid stuck. And we have seen that.
Yeah. And often mothers particularly will focus all of their attention on the kid's health, not taking care of their own health. And invariably, it will help the mom and the dad if they would do limbic retraining also, because many of them have difficulty cognitively getting through their days because they're so involved with taking care of the kids that they're not really involved in self-care. And I know you're all nodding like, yeah, we've seen that.
Mm-hmm.
Yeah, definitely.
Yeah. Kim, do you have a question?
So I feel like the question I planned is kind of taken care of, but there was an really interesting question I saw about should you do the limbic or the nervous system work, right, while you're still in mold? And I know that there's a debate and people get very singular of because you're turning down the reactivity piece, but it's the nervous system piece. So would love your thoughts on that.
My answer is absolutely yes. For a variety of reasons, not everyone who needs to get out of a moldy environment can. It could be financial, it could be a social thing, it could be denial, but you just can't always do that. And I know that Dr. Shoemaker's group absolutely won't treat anyone until they're out of their moldy environment. That's nice theoretically, but in the realistic world that I live in, sometimes I need to get started on treating them early on. So you can get better, not well, but you can get better to varying degrees if you do the limbic and vagal and mast cell work while you're still in mold. Not ideal, but any improvement beats suffering.
Absolutely. I agree. And then sometimes people are like, oh, well, I feel better, I should make the change. I'm like, it's both. You need to do both.
And if you can get some people feeling better, sometimes they feel less cognitively overwhelmed to the point that they can even consider doing it. A lot of our patients are both from a fatigue and cognitive issue are so overwhelmed with the thought of moving or how they would move to, or how can I even find a safer place to move to? Is there a safer place for me to move to? That just paralyzes them, which is a limbic issue and is a vagal issue. So anything that can lift it to any extent may enable them to then move forward a little bit better.
Yeah, one of the things that I've been just impressed with and kind of hold in awe is the ability of people that are really sick to stick with their plan. And they'll get better, but they won't necessarily know that they're better unless we go back to the first visit and read off what their symptoms are. And they'll say, oh, yeah, that's better, that's better, that's better. But they were so sick that they still have multiple levels to go. And I give people so much credit for sticking with that. And especially when they've been told so many times that it's just in their head. or other people, even their family members and things, because they're the only ones sick in the house. And it's like, well, how can you be sick when we're not sick?
It's interesting. Denial is not just a river in Egypt.
Right.
It plays a huge role for many of our patients. Often one family member who views themselves as the glue that's holding it together, they're not going to admit that they have any symptoms at all. And I mean, God bless, they're really doing their best to pull things together. But if people could own what they had, they'd all get better faster. But that, as you know, Alex, is the art of what we do. It's not just knowing how to treat people, it's getting to know those people well enough that we can understand how to motivate them, how to convince them of taking seriously some of our suggestions that otherwise they might not follow through on.
Yeah, I find that oftentimes when it's time to kind of come up with an idea, I might have an idea, but if I ask them what their idea is, they'll have one. And I can't say it's not right. I might like mine better, but I tend to go with theirs initially so that if it doesn't work, they're much more open to a different way of doing things.
Yeah, I agree. That's just good medical practice. If we can honor what our patients want to do, that in a way validates them, that allows them to feel heard. And a lot of our patients have not felt heard. Before they ever get to us, as you all know, they may have seen dozens of other healthcare practitioners who have told them anything from it's in your head to giving them a label that's not useful. For example, a lot of our patients will go to a major medical center and come away with, I now know what I have. I have mitochondrial dysfunction. And then I'll go, of course you have mitochondrial dysfunction. Everyone with mold toxicity and Lyme disease has mitochondrial dysfunction. It's part of the cell danger response concept. You have to. So that's not a diagnosis, nor is it a treatment, because these people need to have their systems rebooted before they'll be able to respond to the things that we give to treat mitochondrial dysfunction. You can't just then lay it on them. It won't work. So, I mean, God bless all of you for doing this work, because we need hundreds, if not thousands of us out there, because there are literally millions of people in this country who are not getting diagnosed or treated correctly because they have mold toxicity and Lyme disease. And I know you all know that.
Yeah. Well, let's get to some of the questions from the audience. Just a quick reminder, if you've asked a question already, please know we're trying to get through all of them. There's some great questions up here already. If you haven't asked it yet, please know that we're unable to answer in-depth personal health questions. So thank you so much for understanding that. All right. Let's see. Write that down. First question, what can you do about low dopamine levels that make it difficult to get out of the bed in the morning?
Okay. There's a lot more than dopamine that gets you to not get out of bed in the morning. Cognition, fatigue. You brought up the issue of airway issues, which are much more common than people realize. Varying degrees of sleep apnea make it difficult to get up in the morning. Mold toxicity and Lyme disease cause pituitary dysfunction, so that thyroid, adrenal, sex hormones are not operating correctly, so that adrenal issues will often lead to that. So to put it in the category of dopamine, I fear that you're going down a very linear road when you want to look at it from a much greater perspective. I also, by the way, and I know people will disagree with me, the way we measure dopamine levels is not that accurate. We can measure it in blood and we can measure it in urine, but that doesn't tell us about what dopamine levels in the brain are, and they don't always correlate. So I wouldn't get hooked on dopamine as the issue. I'd rather that you have your treating practitioner look at it in much greater perspective.
Okay. So where would you start with healing a small child, gut disorders or detoxing mold, metals, pathogens, etc.? And then thank you. They're saying thank you. Your books have helped them with their son's healing tremendously.
Okay. As a general rule, I want to, in functional medicine and integrative medicine, we're taught heal the gut first before you do anything else, right? The exception to that is mold toxicity, which includes candida. And so I've had people work for years trying to use the treatments we use for the gut and not being successful with it because they haven't worked, again, root cause. You've got to get the mold and candida out of the gut to make progress. So no matter how young the child is, and we've even treated 1 or 2-year-old kids along the way, the start is identify that they have whatever they have, be it Lyme disease or mold toxicity, and treat the root cause. If the child is having trouble with that, limbic retraining in a very young child is probably not possible. Sorry, it takes some degree of cooperation. But vagal treatments are out there. Patients can get some osteopathic cranial work. They can get frequency-specific microcurrent. There are some vagal stimulators that are very gentle, like the Apollo Neuro that kids can use. So you can be working on the vagus. You can be working on mast cell activation, which certainly occurs in little ones. And then you want to get at root cause. So my comment is work with a practitioner who knows what order to do things in, because that's really the hang up for a lot of folks, which is sometimes people well-intentioned who have some knowledge aren't doing the right thing in the right order.
Okay. What do you recommend for vagal and limbic? So you mentioned Annie Hopper's DNRS. That's one that we don't recommend as much in clinic. Do you have some other tools? You mentioned the frequency.
I like Ashok Gupta's amygdala retraining. I particularly like Kathleen King's Primal Trust is one of my favorites these days. If I have a patient who has a particular religious concern about those as being more new agey than they're comfortable with, Brooklyn Hanna has a limbic reboot that is particularly geared to people with a strong Christian belief, and they want to get this done biblically if at all possible. That's another one. Those are my favorite. There's one put together by David Hanscom, which is called the DOC, Direct Your Own Care, which is more pain released. David was a pain specialist for years who got into limbic and vagal retraining, and his is more based. So if I have a patient whose cardinal symptoms are pain, I might direct them to the Direct Your Own Care program rather than the others because it's much more specifically meaningful for them. On the vagal side, vagal stimulators, Apollo Neuro, True Vega, working with really sensitive people. The only one that most of my patients can handle is Apollo Neuro. The others, like Gamma Core and True Vega, are too directly stimulating either on the neck or in the ear. It's more of a direct vagal stimulation that kind of is too intense for some of our more sensitive patients. I love frequency-specific microcurrent. I like brain tap. I like things like EMDR or emotional freedom technique. Osteopathic cranial work is a big one for me. Some combination of those. And honestly, the more vagal things people can do, the better people will get. The exercises developed by Stanley Rosenberg in his book, Accessing the Healing Power of the Vagus Nerve is great. But Kathleen King in Primal Trust goes over that in even more detail as part of her program. So combinations, and I want to emphasize that you have to do both limbic and vagal work concurrently if you're going to get anywhere. If you only do one, there's a really good chance that you're not going to settle the system down. They have to be concurrent. And to expand on that, if possible, limbic vagal and mast cell work have to be done concurrently, because there's an incredible, important interweaving between the limbic vagal and mast cells physiologically, all interrelated. And so ultimately, all three systems have to be worked on if people are going to be able to make progress.
Yeah. Amber is asking, what would be an appropriate time period, if no reaction, to see if the supplement works or not before moving on to the next one?
That's a very difficult question, because a single supplement may or may not be helpful. I'll take mast cell activation for one. Mast cell activation, as you all know, is incredibly complicated. Mast cells release over 1,000 biochemical mediators into our system, most of which have an inflammatory component and make whatever the trigger is worse. So you can't just come at it from one substance. I've had a number of patients over the years say, I took quercetin and it didn't work. I took Pepcid and it didn't work. And I fill in the blank. And I'll tell people, one substance may not be able to tell you whether it's working or not. It's a package deal. So if a patient can take a substance with no reaction, I'll ask them to keep taking it and add to it other components. Specifically in the mast cell system, I'll want to have an H1 and an H2 receptor blocker. I'll want there to be a mast cell stabilizer. I like DAO. I like All Clear, which is a tryptase inhibitor. I like leukotriene inhibitors, etc. But that means we're coming at this from as many different perspectives as possible. When all of those are in place, I usually will see people clearly improving. But to get hooked on a single material, as long as it's not bothering them, I'll ask them to keep going with it and not stop, because otherwise they're risking trying to find the one thing that will help. And honestly, it's not going to be there.
I think that's great. Like, if we know it's a mast cell support and they're not reacting, to just keep going with it.
Yeah.
Like, I hear that a lot. Like, oh, I saw no effect from it. It's like, but we had to add another layer.
Right. So when I hear I saw no effect, I'll go, great, keep taking it.
That's
Yeah. I mean, it's again that attitude we bring to the table of helping them to understand that that's really good. That's not a bad thing. And then, so I'm seeing a lot of nodding. You all have had that experience.
Yeah.
Another thing that I've learned from Kim and from Beth is that rather than, even if it's going well, taking something all the way up before starting the next thing, it's oftentimes better to go up a ways and then start your next thing and your next thing, so that you minimize your side effects, but also you're coming at it from different angles, because some of these people don't need the doses that we think they might need to get better.
Yeah. I always tell my sensitive patients respond surprisingly well to tiny doses of things. And that includes mast cell materials. It includes binders for mold toxicity. It includes antibiotics for Lyme disease. That for some reason, the sensitivity also comes along for the ride, an improved response. So I completely agree, Alex, that I have behind me on the wall, you can't see it, there's a little plaque given to me by a patient, and it says, if some is good, more is not necessarily better. And that is, if I have a mantra, that's my mantra. So I agree. I would rather layer small doses of other things on than try to rack it up. And honestly, a lot of our patients have to learn that the hard way. That for whatever reason, a lot of my patients are type A, and they think that if some is good, more is better. And they kind of have to learn that, nope, I was doing really well on this dose, and taking more is not actually better for me. Yeah.
Here's a question that we get frequently. So how does a person know when it's time to wean off mast cell stabilizers and or antihistamines? Is it when you're far along into a mold detox, or when all the mycotoxins are completely gone?
Okay. Actually, it's an easy question. You don't stop limbic, vagal, and mast cell treatment until the mold is completely gone. If you do, it's going to come back and hit you, because what's triggering limbic, vagal, and mast cell issues is the mold toxicity. So if it's not completely out of the system, you're really running a high risk of it coming back on you. I've had countless patients who did limbic retraining for 2 months and said, I did it, and it was really helpful, that's great. And then I'll say, you really need to go back and do it, and they don't. And then a month later, they come back and went, I hate to admit it, but you were right. I should have kept going on the limbic retraining. And the mast cell is no different. You have to keep doing it until the mold is out of the system, at which time you can stop everything. You can actually be cured. And I hope people hear that message, that once you fix the trigger or triggers, you can be cured. You don't have to do all of this for the rest of your life at all.
Mhm. Let's see. So many good questions. You answered a bunch of them. Okay.
Can I ask a question?
Yeah, go ahead, Kim.
Yeah, I'm wondering about with mold, sometimes we see people gain weight and some people lose a lot of weight. It seems to be extremes either way. Would love your thoughts on that and how to best, because I would be concerned that if somebody was storing, right, that they're storing, and when they need to lose the weight, that's more of a mold detox going on later on.
Okay, that is a very good observation. For the people who gain weight, I suspect that the problem is leptin resistance. That mold toxin messes with leptin metabolism, and the body keeps making more and more leptin to try to override leptin resistance. And we'll see, we can measure high levels of leptin in our patients, and that won't get fixed until the mold is out of the body. I mean, so I try to tell people, don't get frustrated. Keep doing a high protein, low carb diet to treat the mold. But when we're done, you will be able to lose the weight. And the majority of my people have. But not everyone's in that category, and not everyone gets leptin resistance. I think there are other more causes for weight loss. One of them most obviously would be a biome dysregulation that is triggered by the mold and candida, in which they're not absorbing food properly. They're not, so that I have seen both, and I think they're very different phenomena.
So Lori's asking, do you have to treat mold and Lyme if mold's the actual root cause, but dormant Lyme becomes activated along with maybe Bartonella?
Okay. Treatment is about getting the immune system rebooted. So we cannot, I don't think we can eliminate every single bacteria of Borrelia or Bartonella or parasite of Babesia in the body, and we don't have to. What we need to do is bring the toxic load down in the mold category. We need to bring the bacterial counts down to the point that the immune system bounces back and recovers. Once the immune system recovers, and to answer this specific question, if someone gets 80% better treating the mold, you may still need to treat Lyme or Bartonella or whatever's left there when we're done. But it is possible that if the immune system bounces back enough, you won't need to do that. And that's really up to that particular patient. I want to flip that around because I think this is a very important concept. It is a robust immune system that determines whether or not mold or Lyme will be active in our body. You can get exposed to mold 10, 20 years ago and be able to deal with mold toxin in your body as long as your immune system is robust. If the immune system takes a hit, COVID was a big thing that made immune systems take a hit, but any infection, surgery, childbirth, an emotional upheaval of any type, the loss of a loved one, a betrayal by, you name it, anything that gets the immune system to take a hit, then Mold, which had been dormant or kept in check by the immune system, can now become a major league issue. The same exact thing is true of Lyme. You can have been bit by a tick any time ago. Your body can keep it under control. And then once you lose containment, then we're off to the races, and it is a serious issue. So I think it is about getting the immune system rebooted, and to whatever extent getting the mold out will do that, will answer that question.
I have lived that exact example with my daughter, who 10 years ago was a healthy senior in college. She got mono and she just crashed, and she just stayed sick. We tested her. She was positive for Lyme, Bartonella, and Babesia. She'd been a veterinary tech on Martha's Vineyard and was exposed to a lot of different things. We treated her for about 2 months with no improvement. Tested her for mold at that point. It was the highest I'd seen, which surprised me. But we stopped all treatment, and for 1.5 years, all we did was treat her mold. 8 years ago, she stopped treatment, and she's had no other treatment since then. We never had to go back and treat the Lyme. And the way that I look at that is that, you know, our body is always trying to be as healthy as it can be, but we have thresholds. And that for some reason in her, the mono pushed her over that threshold. She already had the Lyme and the Babesia, the Bartonella, and the mold, but it was the mold that kept her there once she got there. And I think that that's kind of my mantra at this point, is that you just look for that kind of, or you're aware of those kind of possibilities, that the thing that pushes you over oftentimes is not the primary problem.
Would you say the same is true with COVID?
You're asking me?
You and you.
Yeah, I do. I think anything can do it. Just like what Dr. Nathan was saying about it, could be emotional stress. You know, all kinds of things happen. And so people will come in saying, well, this is what my problem is, because that was time related to when they got sick. But you still have to try to uncover all the other things that might be underneath it.
Yeah. In that same context, and I completely agree with Alex, many people who think they have long haul COVID actually have mold toxicity or Lyme disease, which was unmasked by the COVID. So yes, there is long haul COVID, but a whole lot of people who are getting that diagnosis, because that's the straw that broke the camel's back. That's what triggered the weakening of the immune system to allow these dormant toxins or infections to become activated. And unfortunately, a lot of people who think they have long haul COVID really have mold or Lyme, and we've had hundreds and hundreds of those patients who've gotten well when we treated what was really going on for them.
Yeah, thank you. That's what we see in clinic too. Just it's like the tip of the iceberg. It's just what you see.
Yeah. A few people are asking, because of the discussion around the jaw, what type of practitioners would you recommend people go see to get that evaluation or work done?
I usually recommend that they see Tasha Turzo, who wrote the book on the subject. Tasha's a DO practicing in the Santa Cruz area of California, and she does work with a number of people throughout the country. Typically what this takes is a dentist who is trained in ALF work or other material, combined with an osteopathic physician who knows how to do the jaw and cranial work. So both things need to be done synchronously to get the body to adjust to the incremental shifts in jaw structure that will eventually heal that person.
I will say, especially for the pediatric, because I think one of the other someone else who asked was saying her son had the jaw issues. The person we found for my son is expanding both upper and lower at the same time. And included in that was at their sister office for adults. There's a DO who does cranial sacral or osteopathic work. And it was mandatory to have an adjustment before even getting the expanders put in. So like hearing you say that and just knowing that because of the research I did, I was like, this is it. So anyone can message. Oh, I look frozen on my end. Maybe you can hear me. Okay. I was going to say anyone in the Delmarva area on the like Philadelphia, Delaware, if you want to send support if you're in that area and have a child, I can give you a personal recommendation.
Okay. I see there's some questions here on brain tap and EMF. We haven't really talked about EMF much, and I have 2 chapters on EMF in the Sensitive Patients Healing Guide, and I added a chapter on that in Toxic, which will be coming out shortly, because we are seeing a dramatic increase in EHS, electromagnetic hypersensitivity syndrome. When we changed from 4G to 5G, people think, well, it's no big deal. It's 4 to 5. That's like one number. It was actually an increase of 1,000-fold exposure to electromagnetic sensitivities, and 10G is rolling out as well. So when that happened, there is a dramatic increase in electromagnetic sensitivity. Now, when people who are already limbically challenged, the limbic system is also responsible for all sensitivities, and we're seeing more EMF sensitivity across the board. That also has to be dealt with. That's a whole separate issue. People need to be able to get meters so that they can know what EMFs they're being exposed to in their environment, and there are ways of blocking EMFs. There are environmental engineers who can help you with that. So for some, when I start working with a patient and I start asking questions, the kind of limbic and vagal treatments I can give them depends on to the sensitivities they're telling me. So if they're EMF sensitive, they may not be able to do brain tap. They may not be able to do frequency-specific microcurrent. They can do osteopathic cranial work, may be able to tolerate an Apollo neuro. Most can, but some can't. So we have to modify what we suggest people do by a more comprehensive understanding of what it is that they're going to be reacting to. If they're light or sound sensitive, they can't do brain tap at all. That's off the table. Stevens Porges's safe and sound protocol, not okay for someone who's sound sensitive. So we have to always keep in mind what their sensitivities are so we can suggest things that are more likely to help or be effective.
Yeah. Dr. Nathan, how are you on time? Because we're a little bit over.
I'm okay for now.
Okay.
You're not bored yet, really?
No, we just have so many questions coming in.
Okay, and I want to be sure that I thank all of you for keeping Beth's vision alive and well. I mean, what she did was amazing, and that you're keeping the vision alive is really important. So thank you all for doing that.
Well, thank you for being one of her mentors.
That was my pleasure.
All right. So we answered EMF. We talked about COVID. Oh, here's one about seasonal. This one's interesting because we've people who notice like the cyclical patterns of their symptoms. And then what they're asking specifically, would it still be mold if those allergies are mostly seasonal related?
So the way the immune system deals with allergy is to make a variety of cytokines to help control the allergy. If you have mold toxicity or if you have Lyme disease, that is adding another layer of inflammation to an already inflamed system. So most of our patients who have allergies will be noticeably worse during pollen season, during their allergy season. And that means they need to actively be treating that as well. Now, a lot of the things we use to treat mast cell activation will also take care of allergy, but we may need to do more. So we may need to do things for people who have allergies. We may need to have conventional allergy shots can be helpful for those patients. I'm particularly fond of low-dose immunotherapy, LDI, is a way to deal with those allergies. The American Academy of Environmental Medicine teaches about neutralization potentiation as a very effective way of dealing with those allergies. But we need to additionally treat the allergies during this season to help our patients recover. Otherwise, they're going to just tread water until the allergy season is gone, and they won't be able to make progress.
I agree with that. And for about 25 years, did based upon the Environmental Medicine Academy, the sublingual immunotherapy for people, where they could be tested and they can treat at home with liquid under the tongue that in increasingly higher concentrations, so they actually desensitize themselves. And I've recommended that. We could maybe put on our on the stream here that people can contact a company called allergychoices.com, and they have a find a practitioner feature on their website, so that you can find someone in your area.
Okay. Let's see. So there's some questions coming in about like finding those safe environments. Question about like off-gassing. So if you find a new place, but it has off-gassing, maybe how much time does it take? And this specific person is asking, is there a way to get out of a moldy environment if you're MCAS and super sensitive?
Very difficult question. When we're dealing with that sensitivity, this is often a major league limbic issue. So when people have mold toxicity, number one, their sense of smell also becomes heightened. And many of our patients, as you know, can smell mold when others around them can't. So when they do that, that can trigger their symptoms. The actual exposure to mycotoxins or mold particles can trigger their symptoms. But part of that extreme sensitivity, when people can't find anywhere to live that's safe, is that the limbic system is so hypervigilant that it can, I think, can identify a single molecule of mycotoxin in an environment and then will react to it. The only way I know around it is to really work hard on the limbic system, and you may have to go into a desert environment and live in a tent for a while till this quiets down. Then you will be able to find a place to live. And this is very difficult for some patients who've become that sensitized. I certainly appreciate how difficult that is. It is doable.
Yeah. So kind of along those lines, Maria's asking, is multiple chemical sensitivity only a limbic system condition?
No, it's directly a mast cell condition. In fact, Larry Afrin just published a paper recently showing the direct correlation between mast cell activation and a multiple chemical sensitivity. So multiple chemical sensitivity can be directly triggered by a wide variety of things. In Claudia Miller's research, she's looked at 10,000 people and done all kinds of questionnaires with them. Mold toxicity ranks one of the highest as something that triggers it, but so can various gases that we're exposed to in the home, like propane. There's a wide variety of chemical issues that are intoxicants that can create that issue. But primarily, if you even think about it, with chemical sensitivity, the first thing is the chemical is taken into the olfactory system, which directly connects to the limbic system, and that's why it reacts so quickly. Allergy doesn't work that fast. People can take one whiff of a toxic environment and get brain fog and fatigued, or even have pseudo seizures or kinesthesias. I mean, the only way it can happen that fast is through the olfactory limbic, which takes literally seconds. So the answer is yes, it is limbic, but it is limbic with a mast cell component.
All right, Kimberly or Alex, were there any questions that you saw come in that we want to get to?
Not from now. I've seen a lot of things that we've kind of gone over, and some things that might be better addressed in another forum. I did look up, Dr. Nathan, your citing. It's called Chemical Intolerance and Mast Cell Activation of Suspicious Synchronicity, the one by Lawrence Afron. And so I'm going to have someone put that into the.
Yeah, he wrote that paper with Claudia Miller and
Tanya Dempsey.
And
Tanya Dempsey.
Oh yeah, Tanya. I was blanking on Tanya's name. Tanya's in practice with Larry Afron, and she's excellent. So the three of them, they did write a very nice paper, putting all of that together.
Okay. I have one final question for you. But before we get to that, real quick, I know people are kind of feeling probably all over the place. The biggest thing is like, where do I start? So I think the first place is starting with nervous system. If you are super, super sensitive, hopefully we drove that home a little bit today. But if you're looking for a more personalized approach, you are more than welcome to apply to Mast Cell 360's clinic. You can do a one-time consult with a health coach as a strategy session, or if you're looking long-term big picture, the big picture protocol for mold detox and all of the things, right, would be working with myself or Cam or Kimberly and Alex, right? That's going to be the advanced track. You can find the application at mastcell360.com/application. And all right, my last question for you is, what gives you the most hope when working with even the most sensitive and complex people?
What gives me the most hope is that the vast, vast, vast majority of them have gotten well by my eventually learning what I now know. I kind of wish I knew what I know now 30 years ago, but that is, of course, not possible. If you can really listen to what someone is saying, they will basically tell you how sensitive you are, and then you can orchestrate a treatment program with them that they can do. Now, that doesn't mean there aren't ups and downs to that program. Sometimes I don't guess right. Sometimes I don't get on track perfectly when we get started. But if someone will stick with it, the vast majority of those people will get well. So no matter how sick you've been, there is realistic hope that you can get well. And at the risk of being self-serving, I think if you read my books, particularly the second new edition of Toxic, which will come out at the end of August, and my book, Sensitive Patients Healing Guide. Beth wrote 2 chapters in that book for me. I mean, so it's a compendium. There are 20 guest authors in that book, and these are people top in the field for each subject that we're going over there. I think understanding what's causing sensitivity is knowledge is empowerment. You can then go, oh, I understand that this is not in my head. I'm not making it up. I'm not getting secondary gain. This is a neurological, cellular, physiological shift in my body. We know what it is. And all these experts know how to fix it. So for me, that's realistic hope for people to get well, because in my experience, most of them do.
Alex or Kim, do you have any last words?
I would just say, don't give up hope, right? Keep going and baby stepping, right? In clinic, I feel like we see 2 clients, either the client who's afraid to move forward or the client who wants to rush to the end. And it's a journey, and it's getting comfortable in that middle piece of healing, and get the support you need to do that.
Yeah.
I totally agree with what both of you have said. And I think that it's hard to have hope when you haven't had anything positive happen. But if you can hang in there, there are little things that start to improve that will change your outlook. And even if it's a long haul, being part of a positive journey is generally very uplifting for people. It's incredibly uplifting for us too.
Yeah, I love what I do. I mean, yeah, my work is complicated. I've had colleagues who say, how can you do what you do day in and day out? And I think, how could I not do what I do day in and day out? I mean, I would estimate at this point that we've restored 4,000 to 5,000 people back to health who were really, really sick and really, really unable to function. That's joy in my world. I mean, this is like so cool. I used to have a little wall of the college students who had been sick that were dropped out of college because they couldn't function until we got them well again. And I kind of had a whole wall, all of them getting their degrees from college after they had gotten better. It's like, that's just really uplifting to see these young people get their lives back. It's just beautiful.
Yeah. Well, Dr. Nathan, thank you so much for being here with us today, and everyone who took the time out of their days to learn from you and be with us. Thank you so much. And if you're on the replay, we hope you gained one little piece of that knowledge or wisdom to take with you and feel empowered to take that next step. Thank you guys so much. We'll see you next time.
Okay. Bye-bye.